Dear Chair, dear audience, the title of my PhD thesis is Mechanical and Optical Properties of Enamel and Dentin. My name is Peter. I'm an endodontist resident from Department of Restorative Dentistry and Endodontics and a PhD student from Department of Prosthodontics. My supervisor is Emese and my SMS is Cindy. Currently, I have two ongoing projects. Both of them uses the methodology of systematic review and meta-analysis. The title of the first one is The Effect of Tooth Whitening on Enamel Structure, which is a comparison of in vitro studies. Based on the different published surveys, we can define tendencies among patients regarding their dental aesthetic satisfaction. Based on these tendencies, most of you in this room are currently unsatisfied with your dental appearance. More importantly, more than half of you are unsatisfied with your current tooth color. What could you do in this situation? Tooth whitening. Why? Because it's an easy and a cost-effective procedure. But as with every treatment, it also has its flaws. Most of the in vitro studies report the reduction in the organic and mineral component, which results in the reduction of microhardness. So my aim is to determine this change of microhardness after bleaching and possibly to offer the safest concentrations and safest usage time for patients and dental practitioners as well. Which leads to my clinical question: how do different teeth whitening methods will influence the microhardness of human enamel in vitro? I use the PICO framework, and our hypothesis is that tooth whitening will decrease the microhardness of human enamel. On this slide, you can see my systematic search, and after completing each step, I was left with 144 eligible articles. Before jumping to the results, I would like to give you a brief review on how the experiments are carried out, because it will be important to understand the results. After the extraction of teeth, the root portions are cut off, then we create enamel slabs and we embed them in acrylic resin. Then we do a microhardness measurement, which will be termed as before bleaching. It's a baseline measurement. Then we do the bleaching, hopefully, according to the manufacturer's instruction. During the experiment, if needed, these enamel slabs should be kept in artificial saliva and in 37 degrees Celsius. After the bleaching session, we do another microhardness measurement, which will be termed as after bleaching microhardness value. Although it seems nice, there are many factors that are changing among the experiments. To make more understandable, I group them in two. The first one is dealing with the experiment set. The type of indenter, the load of indentation, and the time of indentation differs among papers. The second one is more obvious. It's dealing with the bleaching agent. Obviously, the concentration and the usage time of these products differs. It gives us a really complex picture, but we have to solve it. At first, I had to review each of the eligible papers and define the possible experiment sets. That's what you can see in the first two rows of this column. On the first two column, you can see that the different subsets and subgroups based on the concentration and usage time. If in this table you can see, let's say, a globing scale cell, that means that there is sufficiently enough data for statistical analysis. I don't think I have to underline that it will be important if in one experiment set we would have sufficient data in all subsets and all subgroups, which is luckily the case for Knoop indentation 55 gram load for 5 seconds. So let's see the result of this experiment set. We decided to create ratio of means. It's a calculated number from before bleaching and after bleaching microhardness value. It's a percentage value. It means, for example, if the ratio of means is 90%, that means that the microhardness decreased from the baseline 100% to 90% due to the bleaching. In the first subset, we see very low concentrations of hydrogen peroxide, below 6%. That is because the currently available European guideline does not allow nor patients nor dental practitioners to use any products that contain more hydrogen peroxide than 6%. If we look at the results, we see that using these products for 2 weeks or 2 to 3 weeks, no significant damage could be seen. However, using them for 6 weeks, significant damage. If we look at the second subset, using moderate concentrations, we could see the same. Using them for 2 to 3 weeks, no significant damage. For 6 weeks, we could see significant damage. If we look at the third subset, we see high concentrations of hydrogen peroxide, which is commonly true for in-office bleaching, where the bleaching is carried out by a dental practitioner. We could see on the results that using them for above 90 minutes can cause significant damage to the patient. With this figure, I just want to give you input on what we are currently working on. The ideal for a dental practitioner would be to see the change of ratio of means independence of time. But currently, as you can see, the data are pointing in too many directions to have a clear conclusion. What are the strengths and limitations? Strengths are the large sample size, in-office and at-home bleaching included. We only use studies that used human enamel, and Vickers and Knoop indentation included. Among the limitations, I would like to underline the last one, which is the protocol deviation. Unfortunately, some authors reportedly or unreportedly overused the products, which would shift our results in an unwanted direction, so we had to exclude these papers. What are the conclusions? At-home bleaching shouldn't be used more than 3 weeks, and in-office bleaching shouldn't be used more than 90 minutes. Our implication for practice is that bleaching products should be used according to the manufacturer's instruction. That is the biggest one. And also, patients shouldn't use at-home bleaching products more than 3 weeks. An implication for research, the ideal would be the standardization of measuring methods, and our opinion is that the effect of pH should be investigated more carefully because it can be the cause of the microhardness decrease due to bleaching. So I have my partial results, and our AIM journal is Journal of Dental Research. On this slide, you can see my first project progress, and I would like to jump to my second topic, which is effectiveness and safety of tooth whitening in patients. The background is quite similar. Most of you are still unsatisfied with your current dental appearance. You still don't like the color of your teeth, and you still want to treat it with tooth whitening. However, in vivo, the biggest flowback reported is tooth sensitivity. It can hit even the prevalence of 93% among patients. So my aim is to determine whether this treatment, so what is the cost benefit of this treatment? Because I can tell you that in a very high chance this flowback will occur. However, I cannot tell you how much will you benefit from the treatment. This leads to my clinical question. What is the benefit of tooth whitening in terms of effectiveness and safety? Effectiveness is measured through shade change or color difference, and safety is measured through visual analog scale or other sensitivity pain measuring scales. Our hypothesis is that the effectiveness is low compared to the occurrence of complications. And our clinical implication is, as I said, to determine the cost benefit of this treatment. We have finalized our search key and we sent it in for submission. I've also sent my Prospero registration to the statistician. We are waiting for the feedback. So these are my two ongoing projects, and I would like to thank you for your attention with a quote from the famous dentist, Dr. Stefan Bergen. Color may be unimportant to the physiologic success of a dental restoration, but it could be a deciding factor in patients' acceptance. Thank you so much.
If you could go back to the first plot, is it possible?
Yes.
Here. So at the 42 days, I can see that there's the same publication, so I can assume that's 5 different subsets of patients. What's the difference between these group of patients?
Yes, it is actually, let's say, sad that only one author decided to investigate the effect of tooth whitening in such a long scale. The difference between each line is that different products were used, different commercially available products. The concentration may be the same, or the treatment time might be the same, but since it's a different product, it has different composition, so it should be termed as a different, let's say, measuring sequence.
I have a question regarding the safe usage of these bleaching agents. So we can see that longer period of time comes with considerable microhardness decrease of the enamel, but I believe with time and with the remineralization process, these species will regain their microhardness. Do you know, or do you have any information? What is the suggested or required period of time between two or repeated tooth whitening procedures?
Yes, it's almost the most frequently asked questions I get. That's why we try to work on this figure, because we experienced that there are, let's say, follow-up studies. In these follow-up studies, after the end of teeth whitening, they continue to soak them in artificial saliva, and they constantly measuring the microhardness. And the question is, of course, the artificial saliva is changed daily, but the question is the same, that how much time should pass to regain this microhardness to the baseline level. We plan to investigate it, and we plan to see more data, but currently this figure is not telling us any sufficient information.
As I understand, you mentioned that 6% hydrogen peroxide is banned in the European Union.
Yes.
And what is the cause of this? So what is the cause of this restriction?
Yes, thank you for your question. We have... So we know why they say, but it's not reasonable. In the USA, they are not so strict. This specific 6%, according to my best knowledge, is based on in vitro studies which were carried out in bovine enamel, so not even human enamel, but bovine enamel. And they could see that using 6% didn't cause any significant damage, so they try to be as cautious as possible to save the patient from possible damage. But what I'm trying to do here is to prove that this is an unnecessarily strict regulation.
Are you planning a clinical trial in this topic in the future? Because I think a lot of people would take part in it.
Yes, that would be lovely. So we are planning, yes.
Nowadays, the products are, as far as I see, rather alkalic instead of acidic. Do you have any data? How would that influence the microhardness?
Most of the products that I have seen use neutralized or acidic pH. In these in vitro studies, I did not experience alkalic pH, so unfortunately not.
That's the latest direction.
Yes, thank you.